Every minute, more families hear words they never forget: memory loss, cognitive decline, possible dementia, and for some of them, the cause is not simply age, it is not bad luck, it is not always an unavoidable disease process marching forward on its own. Sometimes it is something far more ordinary: a medication, a pill taken every day, a product sitting in the bathroom cabinet that nobody ever thought to question because it came from a doctor, a pharmacy, or a familiar store shelf. I'm Dr. Marie Clark, and after years of caring for older adults, I can tell you this with complete honesty. One of the most overlooked threats to memory is medication-related cognitive decline. Not because the medications are always wrong, not because they never help, but because many of them carry risks that are rarely explained clearly, especially to seniors and the families trying to protect them. Today, I'm walking you through 9 medications and medication groups that could be quietly increasing dementia risk or worsening memory problems in older adults. Some of them are prescription drugs. Some are over-the-counter. Some are taken for sleep. Some for bladder issues, some for anxiety, and some for problems that sound so harmless most people never think twice. And watch closely for number 3, because it is often treated like a simple sleep fix, while the brain may be paying a much higher price. Before we start, one important note: never stop a prescription medication on your own. Some of these drugs must be tapered slowly and carefully. The goal is not panic. The goal is awareness, because once you know what to look for, you can ask better questions and protect your brain more intelligently. Let's begin with number 9. Number 9 is diphenhydramine. You know it as Benadryl, and you also know it by many other names hiding in nighttime cold medicine, allergy pills, and those so-called PM sleep products people take without a second thought. This is one of the most common traps in America. A person cannot sleep, so they take one little pill, or allergies flare, so they take it for a few nights. Then a few nights become a habit, and what felt harmless starts becoming a steady drain on mental sharpness. Diphenhydramine is strongly anticholinergic. That means it blocks acetylcholine, one of the key brain chemicals involved in attention, alertness, and memory formation. Younger brains can sometimes compensate. Older brains often cannot. That is where the trouble begins. What people describe is subtle at first: more grogginess in the morning, slower thinking, trouble finding the right word, forgetting why they walked into a room. Then, over months or years, the fog becomes so familiar they stop noticing it. Their family notices, their friends notice. But the pink pill by the bed never gets blamed. If you take it for allergies, ask whether a non-sedating option like loratadine or cetirizine makes more sense. If you take it for sleep, that is an even bigger red flag, because sleep aid use tends to become chronic very quickly. Number 8 is the proton pump inhibitors, omeprazole, esomeprazole, lansoprazole. These are the reflux and heartburn drugs millions of adults take daily. Now let me be fair, these medications can be very helpful and for some people very necessary. But problems start when a short-term treatment quietly becomes a permanent lifestyle. One refill becomes 10, 1 month becomes 5 years. Why does that matter for the brain? Because long-term acid suppression can interfere with absorption of nutrients older brains depend on, especially vitamin B12 and magnesium. Low B12 alone can contribute to numbness, fatigue, confusion, and memory problems that can look frighteningly similar to early dementia. Some studies have suggested an association between long-term PPI use and higher rates of cognitive decline, though the research is still debated. What is not debated is that prolonged use deserves periodic review. If someone has been taking one of these drugs for years and nobody has reassessed whether they still need it, that is a conversation worth having. The question is not, should everyone stop? The question is this still necessary at this dose, and has anyone checked what it may be costing elsewhere? Number 7 is oxybutynin and similar overactive bladder medications. This one breaks my heart because the problem it treats is so personal. Urgency, accidents, fear of leaving the house. Older adults take these medications because they want freedom and dignity back, and they deserve both. But many of the older bladder medications are also strongly anticholinergic. Once again, they block the same memory-supporting chemical the aging brain is already struggling to preserve. Oxybutynin is one of the best-known examples, and one of the most concerning in older adults because it crosses into the brain so easily. The result can be devastatingly easy to miss. A person feels more in control of their bladder, but less in control of their thoughts. They lose their train of thought mid-sentence. They misplace important items. They feel less mentally present. And because the decline is gradual, it gets written off as normal aging. But normal aging does not mean nobody should question the prescription list. Newer options, including non-anticholinergic bladder treatments, may be safer for some patients. That does not mean they are right for everyone. It means older adults deserve to know there may be alternatives. Number 6 is benzodiazepines. Medications like lorazepam, alprazolam, and diazepam. These are commonly prescribed for anxiety, panic, and insomnia. And in the short term, they can feel like relief itself. The nervous system softens, the body finally calms down, sleep comes, panic loosens its grip. But the brain pays for that calm. Benzodiazepines can impair attention, slow processing speed, reduce memory formation, and increase the risk of falls and delirium, especially in older adults. Some research has also linked longer-term use to higher dementia rates, though separating cause from correlation is complicated because anxiety and sleep disturbance themselves can affect cognition. Even so, the day-to-day effect is often obvious. People on these medications for long periods may feel flatter, slower, more forgetful, less steady, and less like themselves. And the longer they stay on them, the harder it can feel to come off. That is why I need to say this clearly. Never stop a benzodiazepine suddenly. Withdrawal can be severe and even dangerous. If this medication is on the list, the right move is a careful medical review and, if appropriate, a supervised taper. Number 5 is amitriptyline. This is an older antidepressant, but many people are not taking it for depression at all. They are taking it for nerve pain, migraines, or sleep. That is exactly what makes it so easy to overlook. Amitriptyline is another medication with a heavy anticholinergic burden. In plain English, it interferes with one of the brain's most important memory systems. And unlike some medications that cause only mild cognitive slowing, amitriptyline can produce a very noticeable mental cloud in older adults. A person may say, "I just don't feel as sharp anymore. I cannot hold on to new information. I lose the thread halfway through a conversation." That matters. Because when a symptom appears gradually, families often adapt to it instead of investigating it. For some patients, there may be safer alternatives depending on why the medication was started in the first place. But the first step is not guessing. The first step is identifying that the medicine could be part of the picture. Let's keep going, because number 4 is one many people assume is a safer modern choice. Number 4 is paroxetine, also known as Paxil. Paroxetine is an S3, a class of antidepressants often viewed as more tolerable than older psychiatric medications. And in many cases, SSRIs are indeed better choices than older drugs. But paroxetine is different from several of the others in its class because it also has meaningful anticholinergic effects. That one detail changes everything for some older adults. The concern is not that every person who takes paroxetine will develop dementia. The concern is that in a vulnerable aging brain, a drug used to stabilize mood may also contribute to confusion, slower recall, and reduced mental clarity. Geriatric prescribing guidelines have warned about paroxetine in older adults for exactly that reason. This is especially important because depression itself can already look like memory loss, anxiety can scramble, poor sleep can weaken focus. So when a medication adds another layer of cognitive burden, families may not know what they are seeing. If paroxetine is on the list, that does not mean it was a bad prescription. It means it may be worth asking whether a different antidepressant would offer similar benefit with less cognitive downside. Now we come to number 3, and this is the one I told you to watch. Number 3 is the prescription sleep medications people often call sleeping pills, zolpidem, ezopiclone, zaleplon. These medications are often marketed and perceived as cleaner, lighter, gentler alternatives to older sedatives. That is exactly why they are so deceptive, because what sounds like simple help for sleep can become a major problem for memory, nighttime confusion, balance, and next-day functioning, especially in older adults. Here is what families sometimes miss. Sleep medications do not create natural sleep in the same way a healthy brain cycles through it. They sedate, they suppress, they can leave people less alert the next morning and more vulnerable to confusion at night. In older adults, that can mean wandering, falls, bizarre nighttime behavior, and memory gaps that start to accumulate over time. And once a person believes they cannot sleep without the pill, the medication becomes psychologically powerful even when it is no longer serving them well. That is why geriatric experts repeatedly caution against routine long-term use in seniors. If a person is taking a sleep drug most nights, that deserves a closer look. Sometimes the deeper issue is untreated sleep apnea, depression, pain, late caffeine, poor sleep habits, or another medication already interfering with rest. Number 2 is antipsychotic medication used in older adults for agitation, restlessness, or sleep. Medications like quetiapine, risperidone, and olanzapine were developed for serious psychiatric conditions, yet in real life, many older adults are exposed to them for reasons far outside those original uses. A little nighttime agitation, some confusion, difficulty settling down, behavior that overwhelms an exhausted caregiver, and suddenly a very heavy medication enters the picture. These drugs can cause profound sedation. They can dull emotional expression, slow movement, worsen balance, and make a person seem farther away even while they are still sitting right in front of you. In people with dementia, antipsychotics also carry serious warnings, including higher risks of stroke and death. I want to be careful here. Sometimes these medications are used for good reasons and in very difficult situations, but they should never feel routine, and they should never be invisible. Families deserve to know why the medication was started, what behavior it is targeting, whether it is helping, and how soon it can be reduced if the situation improves. Because sometimes what looks like worsening dementia is, at least in part, medication effect. And now we reach number 1. Number 1 is not one pill. It is the combination, the stacking, the burden. Almost nobody adds up. Number 1 is anticholinergic polypharmacy. This is where the real danger often lives. Not in a single prescription, but in the total weight of several medications, all pushing the brain in the same bad direction. One pill for allergies, one for sleep, one for bladder control, one for nerve pain. Each one alone may seem manageable. Together, they can overwhelm an older brain's ability to compensate. Memory slips become confusion, confusion becomes dependence, dependence gets mistaken for decline that was never inevitable. This is why medication review matters so much. Not a quick glance, a real review. Every prescription, every over-the-counter product, every supplement, every nighttime aid, every as-needed pill nobody thinks counts. Because when the overall anticholinergic burden comes down, some people improve. They get clearer, more awake, more themselves. Not every case is reversible, not every memory problem is medication-induced, but enough of them are worsened by medication that ignoring the list is no longer acceptable. So here is what I want you to do after this video. Open the cabinet, read the labels, write the names down, then bring that full list to your doctor or pharmacist and ask for one thing plainly: a cognitive risk medication review. Not because you want to stop everything, not because you want to fight every prescription, but because your brain deserves the same protection your heart, your blood pressure, and your joints already get. I'm Dr. Marie Clark. If this made you think differently about what is in your medicine cabinet, pay attention to that feeling. It may be the warning that helps you catch a problem early. And if you know someone over 60 who takes more than one daily medication, share this with them. It could help them ask the question that changes everything. Stay sharp. I'll see you in the next one.